there are two poles, tuberculoid leprosy and the lepromatous leprosy, and so everything falls in between two. So these are two poles. We have lepromatous leprosy, borderline leprosy, borderline lepromatous leprosy. That is your BL, then borderline leprosy, borderline tuberculoid leprosy, and tuberculoid leprosy. In Madrid classifications, we have four classification: lepromatous type, borderline, then we have intermediate type, and the tuberculoid type. And Indian classification, we have lepromatous type, borderline, intermediate type, and pure neurotic type and tuberculoid type. So we have these classification of lepromatous leprosy. So you need to remember that there are two broad classifications, two poles. There's lepromatous leprosy and there is a tuberculoid leprosy, and in between we have borderline, intermediate, and so on and so forth. So basically, the two clinical classifications are, that is your two categories which are used in leprosy control program are the paucibacillary leprosy and the multibacillary leprosy. The paucibacillary leprosy is when the leprosy fulfills these criteria. That is, the skin lesion, if you see is 1 to 5. Skin lesions, there is no nerve involvement, and the slit skin smear, which we prepare for the diagnosis, is negative for lepra bacilli. That when they are negative for any acephalous bacilli, so that is known as a paucibacillary. As the name suggests, pauci, that means less number. So everything is less. Then there is no nerve movement, no nerve involvement. The skin smear is negative for lepra bacilli, and the skin lesions also, there are few, either 1 to 5. The multibacillary, as the name suggests, multi, it fulfills the criteria when the skin lesions are greater than 5, or there is a nerve involvement, or the split skin smear is positive for the lepra bacilli. So, as I told you, leprosy is they broadly classified into two types: lepromatous leprosy and lepromatous tuberculoid leprosy. So it's a bipolar disease. So there is a classification. So there are differences between the lepromatous leprosy and tuberculoid leprosy, and this is important for you to remember. So coming to the bacillary load, in lepromatous leprosy, it's a multibacillary. So here the number of bacilli will be more, the lepra bacilli. The tuberculoid leprosy is a paucibacillary. Then coming to the bacteriological index, here it's 4 to 6. That is more. Here it is 0 to 1. Coming to the skin lesions, so need to remember is that in lepromatous leprosy, large number of acid bacilli seen. That is, it's multibacillary. Large bacteriological index is more as compared to your tuberculoid leprosy. And now coming to the skin lesions, here the skin lesions are many. Okay, so much more. Skin lesions are many. And it's a symmetrical. The skin lesions you see, it has a symmetrical margin. Symmetrical lesions with irregular margins they appear, and as a multiple nodules, that is known as leptomata, or a flask and xanthoma like papules. And these form a typical leonine species. The lion-like species are seen in this in lepromatous leprosy, and there will be loss of eyebrows, loss of lashes, which is seen, and the face will appear like a lion-like, which is seen in case of lepromatous leprosy. But in tuberculoid leprosy, here these skin lesions are one of few with asymmetrical margin, which is sharp. And here you see the hypopigmented patches, hypopigmented annular macules, which is seen, which have elevated borders, and they have a tendency towards central clearing. So central will be clear, and the margins will be elevated, and they are hypopigmented annular macules. which we see in case of tuberculoid leprosy. So the margins are elevated. So the skin lesions are different in case of both lepromatous leprosy and tuberculoid leprosy. Now coming to the nerve lesions. So this disease, it involves skin, basically leprosy involves skin and nerves. As I told you before, that it involves skin, nerves. So in lepromatous leprosy, give me a second. Just a second. So in nerve lesion in case of lepromatous leprosy, it appears late. The nerve lesions appear late. This hyposthesia is a late sign which is seen. But in case of tuberculoid, the nerve lesion signs, they appear early. So the the nerves will become thickened and enlarged, and sometimes nerve abscess is seen. In case of tuberculoid leprosy, more in case of borderline tuberculoid leprosy. Now coming to the cell-mediated immunity, here the cell-mediated immunity lepromatous leprosy is low, and the prognosis is not good, it's poor. Whereas in case of tuberculoid leprosy, the cell-mediated immunity is intact. It's adequate. So the lepromin test is also positive. In case of tuberculoid leprosy, here the lepromin test is negative. If the cell-mediated immunity is poor, so lepromin test will not, it will not show in case of lepromatous leprosy. So that is the lepromin test is negative. And in tuberculoid leprosy, cell-mediated immunity is intact. It's adequate. Therefore, your positive, the lepromin test is positive. Sorry. Now coming to humoral immunity, it is exaggerated in case of lepromatous leprosy, whereas it is normal in case of tuberculoid leprosy. Now, in lepromatous leprosy, we find these lipid-laden macrophages, these leprobacilli. They appear in groups with lipid-like structures, and they are inside the macrophages. So they like foamy type of a lesion. So here the macrophages are the foamy type, which is lipid-laden. Here it is epithelioid type. This see in pathological samples. Then Langerhans cells, they are not seen in case of giant cells. They are not seen in case of lepromatous leprosy, and they are seen in case of tuberculoid leprosy. So these are the differences of lepromatous leprosy and tuberculoid leprosy, and this is very important for exam point of view. You can straight away get a question on this. So if you see, this is the nodular lesion of lepromatous leprosy. These are the nodular lesions which are seen, and in tuberculoid leprosy, they are hyperpigmented patches. You see, these are the hyperpigmented patches which raised border. Center is clear. Now the other categories, apart from these two main categories, borderline type, and it is as the name suggests, borderline. So it is, these patients, they have both features of tuberculoid, something in between the tuberculoid leprosy and the lepromatous leprosy, and they may shift to either tuberculoid leprosy or your lepromatous leprosy type, depending upon the host alteration, host resistance, or the chemotherapy. Then this intermediate type. This denotes those early unstable cases with one or two hypopigmented macules and definite sensory impairment. Here the lesions, they are bacteriologically they are negative. Then we have this pure neurotic type of lesions. These patients, they have nerve involvement, neural involvement is seen, and there is no skin lesions are seen. So they have more of they have this nerve involvement without any skin lesions. Those are the pure neurotic. That is why the name pure. So we have this nerve involvement with no skin lesions. And here also the bacteriologically these cases are negative. So these are the other categories apart from the lepromatous leprosy and tuberculoid leprosy. Now coming to the immune response. So immune response is very important. So in case of lepromatous, in case of leprosy, because immune response it determines the outcome of the disease. As I told you, like in lepromatous leprosy, CMI is not it's very poor, and in case of tuberculosis leprosy, the CMI is good. So that is why the immune response is very it has a major role to play in case of leprosy. Here in innate immunity, this high degree of innate immunity is shown to leprobacilli, and minority of these, those which are infected, they develop the clinical disease. Cell-mediated immunity, it plays an important role in the control of the disease. So, leprosy it's a obligate intracellular parasite, right? So that is why CMI plays an important role in the control of the disease. So those people who have the low CMI, they tend to develop the lepromatous leprosy type of lesions, and the people who have good immune system intact, they develop the tuberculoid type of leprosy. Now, the humoral immune response, the antibodies, since it's an intercellular parasite, so antibodies, they don't have much role in the control of the disease. But and antibodies, but in this lepromatous leprosy patient, there is an exaggerated Ph2 response, and which leads to release of cytokines that leads to increased polyclonal B cell activation. So there will be high titer of antibodies which is seen in case of lepromatous leprosy, which is both specific and non-specific type. Now coming to the complications. So complication in leprosy, patients, they, as I told you, they lead to deformities, which are seen in case of leprosy patients. If you've seen leprosy patients, they have these deformities, and so one of the most common complication deformities. Another is allergic response, also known as the leper reaction. So these deformities, um, so out of the 25, so out of all the leprosy cases, 25 untreated cases, they develop in deformities. So deformities, they may arise due to nerve injury. So they could be muscle weakness or paralysis seen, or this could be because of, there's a disease process. They have these, there's a loss of eyebrows, eyelashes. There's the facial structure will change, or sometimes they could be deformities can occur because of infection or injury, so which leads to ulcers. So common deformities which are seen is on the face is leonine facies, that is they have this lion-like facial features. There will be sagging of face, the loss of eyebrows, eyelashes, saddle nose. There will be corneal opacity and ulcers. Then on hands, you'll see like there'll be because of the paralysis, there'll be wrist drop or there's a claw hand. Then on feet, there'll be foot drop because of nerve involvement. There'll be clawing of toes because of the nerve involvement or inversion of toes or plantar ulcer. So these are the various deformities which uh, um, these patients, and these occur because of your nerve involvement or because of the disease or infection which can occur later. So this picture is showing uh, deformities in untreated lepromatous leprosy. This is saddle nose deformity. Then this is bony deformity, which is seen, and along with the corneal bony deformity, along with the corneal opacity, uh, it is seen. These are the deformities which are common in case of leprosy. Now coming to the lepra reaction. So these patients also, apart from the deformities, they can show reactions. So lepra called as lepra reactions. So these reactions they are called as lepra reaction. You know the two types, type 1 and type 2. So type lepra reaction type 1, it is a type 4, that is your delayed hypersensitivity reaction, and lepra type 2 is your type 3, that is immune complex mediated reaction. Uh, Please recall your uh, immunity chapter, your hypersensitivity chapter. This has been covered over there. So type 4 is also seen in other diseases, some very common diseases, or tuberculosis. Then it is seen with type 1 reaction seen in borderline leprosy, type 2 reaction is seen in lepromatous leprosy varieties, lepromatous variety that includes the borderline leprosy or lepromatous leprosy. Type 1 reaction is manifest as inflammation of lesions, previous lesions, appearance of new skin lesions, or the inflammation of nerves, that is on neuritis. Well, in type 2 reaction, so there will be appearance of painful erythematous papules, which appear in the crops in the form of, there will be appearance, large a number of appearance of these painful erythematous papules, which become nodular. But which become nodular, also known as the erythema nodusum leprosum, ENL. Then lepra reaction type 1, it occurs before treatment. So it progresses to lepromatous leprosy, which is a downgrading reaction. And if it occurs after treatment, it progresses towards tuberculoid leprosy. That is, there will be the reversal of reaction, which is seen. And type 2 reaction, it is generally occur following the chemotherapy. Now coming to T helper response, in type 1, Th1 predominates, which leads to your activation of interferon gamma and interleukin 2. Here the Th2 response predominates, which leads to release of your interleukin 6 and interleukin 8, and TNF alpha, which plays central role. So these are the the responses of T helper cell, which is seen. So here in lepra 1, Th1 predominates, and in here Th2 predominates. So accordingly, the cytokines which are released are different. Then it usually other organs, they are not infected in case of lepra reaction type 1, but in lepra reaction type 2, if this reaction involves other organs like eyes, testes, kidney, these organs, they become infected. Now coming to the treatment, lepra reaction type 1, in this we give glucocorticoids, whereas in 2 we can give glucocorticoids, thalidomide, clofazimine, and antipyretics. So this is the difference which is seen in case of lepra type 1 and type 2 reaction. So this is a complication. So we need to remember there are two complications: deformities and the lepra reaction, which is seen in case of leprosy patients. Now coming to the epidemiology. Um, so what is the source of infection? as I told you, there are two type of cases which we see. There's multibacillary and multibacillary cases, which includes the lepromatous leprosy and borderline leprosy. These are the most. These are the lepromatous leprosy infectious as compared to tuberculosis leprosy. So they are most important source of infection. And since it's a multibacillary and tuberculosis leprosy is a paucibacillary, so they don't are much involved in the transmission process. They do not transmit infection that efficiently. So mode of infection is that one can get infection through nasal drop, uh, uh, nasal drop infection containing the generation of aerosols containing the M. leprae. So this is the most common mode of infection. Another are through contact with skin. So one can get infection, when there is a direct contact of infected person to another person, or one can get also infection through indirect contact, that is with infected soil, fomites, clothes and linen. Then apart from these, the direct dermal inoculation can also occur during tattooing. So these are the mode of infection. Now coming to the communicability, leprosy is not that contagious disease, but it get transmitted when there is intimate and prolonged contact between the infected person and non-infected person. The intimate contact is required in case of transmission of leprosy. Apart from these, the environmental factors like people of rural areas, with moist soil, humidity, and overcrowding, they may play a role in the transmission of the disease. And has been seen males are infected more as compared to females. Now coming to the leprosy elimination, in 1992, WHO had launched the campaign to eliminate leprosy, and where the goal was less than one case per 10,000 population, and India achieved this elimination status by December 2005. Okay, it's 2005. Then this global leprosy strategy, which was launched by WHO in 2006, this was aimed to reduce the disability among children. So this disease is common, it's worldwide in distribution, and we do have in our country as of in March 2018, 90,000 more than 90,000 cases were recorded. Laboratory diagnosis. So now coming to the most important thing is your sphere. You can get them in directly or in your microscopy, and they are the acid-fast bacilli. So we see these acid-fast bacilli in the lesions. These are comparatively less acid-fast as compared to your tubercular bacilli. So what are the specimens which we can collect? So specimens we collect skin lesions basically. They pour from the skin, forehead, cheek, chin, buttocks. Those total 6 samples are collected. Then one from earlobe and nasal mucosa by nasal blow or scraping. Then we pair this slit skin smear, which is we clean the area with spirit. We pinch the skin. We hold it tightly so that the bleeding is minimized. Then we make a incision with the help of a scalpel, 5 mm of incision, and deep enough that it infiltrates the layers of skin. Then we take the lesion. We take this, after putting the scalpel blade, we rotate it transversely. We take the scrape, we scrape the sides and the base of the lesion of the incision. and we take the tissue pulp. We take out that tissue pulp. Basically, we take the skin tissue. Then we take out it, we prepare the slides, we put it on a slide, we spread it at in an area of 18 mm diameter on the slide. So we prepare the slit skin smear. Then we can also take nasal samples. We can take those nasal samples from, we can ask the patient to blow, uh, which will have this mucous material in it. Or we can also go for scrapings, nasal scrapings with the help of scalpel, scraper. We can scrape the mucosa of the nasal area, the nasal septum. So what we will do, we will take the samples. We can also take the skin, your skin nerves. We take the biopsy of the nerve or the any nodular lesion which we see. We can take the biopsy of that specimen. Then we prepare. We do the acid. These are acid fast bacilli. So we will do the Nielsen staining. So these are less acid fast as compared to your tubercular bacilli, and here we use 5% of sulfuric acid for decolorization. Okay, so this is the difference between what we do in case of Mycobacterium tuberculosis and Mycobacterium leprosy. अभी पूछते भी हैं एग्जाम में, वाइवा में पूछ लेते हैं टेक्निक में क्या डिफरेंस है, you know? And so we will look for these red acid fast bacilli under oil immersion. And these bacilli, they are arranged in the, these are cigar shape and they are arranged in the form of group. They are arranged in the group. And call us, this light substance which forms, the globi in your macrophages. They give a foamy cell appearance. So that is why you see these foamy cell macrophages. These are the lepra bacilli. Okay, and these are arranged mostly in the groups in the cigar-like bundles. We find these dead bacilli, live bacilli. So live bacilli are uniformly stained. They have the parallel sides and round ends, and their length is 5 times the width. And the dead bacilli, though we identify them that they are less stained uniformly, and they have granular and the fragmented appearance. So this is how we identify the live bacilli and the dead bacilli. So there is a grading of the smear, which which is there in case of leprosy, that if we see 1 to 10 bacilli, 100 oil mushroom field, then it is graded as 1 plus, 1 to 10 दिखेगा, 10 oil immersion field में तो 2 plus, 1 to 10 bacilli per oil immersion 3 plus, 10 to 100 4 plus, and if you see 100 to 1000 bacilli 5 plus, and greater than 5 bacilli which are arranged in the form of clumps and globi, then we give it a 6 plus. So we have this grading of the smear in case of leprosy, as we have in the case of sputum for Mycobacterium tuberculosis. We have these. This bacteriological. We take out the bacteriological index and the morphological index. So bacteriological index is that when the total number of bacilli, whether it is dead or live, it is total number of bacilli per oil immersion field, which includes your both live and dead bacilli. And that is why we need to know how the dead bacilli and live bacilli look like in order to take out the bacteriological index. So it will give a total number. Then the morphological index is there's a percentage of uniformly stained bacilli out of the total number of bacilli. So here we are looking for the live bacilli. The percentage of uniformly stained bacilli out of the total number of bacilli counted. And it is so this morphological index is a better marker to monitor the treatment response. So following clinical treatment improvement by treatment, if the treatment is proper, if the patient is responding, then your MI index should fall, because live bacilli, obviously, if the treatment is going fine, the patient is responding, this MI index will come down. and your bacteriological index will go up because there will be dead bacilli also seen. So dead का number ज़्यादा हो जाएगा, live का number कम हो जाएगा. So in total, your morphological index will go down and your bacteriological index will go up. Then this SFG percentage, that is a solid fragmented granular rod percentage. It gives a better picture of bacterial morphology and is more sensitive indicator of monitoring the treatment response than your MI. So this was about smear. We can do smear microscopy, then mouse cultivation. So we cannot culture them in artificial media or in tissue culture like we do for viruses. We can cultivate in footpad of mice. ये बहुत important question है. जब भी वाइवा होता है तो पूछते हैं कि माइकोबैक्टीरियम ट्यूबरकुलोसिस किसमें ग्रो करता है, लॉवेंस्टीन जेंसन मीडिया. Then we ask mycobacterium leprae, or we ask what else grows in that. So generally you say mycobacterium leprae. So mycobacterium leprae doesn't grow. We don't have any media for it, any artificial media for it. Okay, तो ये ग्रो करता है तो फुटपैड ऑफ माइस में. That is 9 kept at 20 degrees centigrade for 6 to 9 months. Or we can use the armadillo, and banded armadillo is there. So, for the it's more sensitive, right? Because we are growing it, we are culturing the bacteria in our animal. So the sensitivity it will increase, and it will since we are growing it, we are culturing. So we can the organism, the bacteria, so we can detect the drug resistance and evaluate the potency of drug. We can take advantages of apart from culture, we can go for antibody detection. We can use this fluorescent leprosy antibody absorption test. It identifies the subclinical cases and their antibodies detected irrespective of duration and the stage of the disease. So this test is 92% sensitive and 100% specific. We can also go for the ELISA, which can detect your antigen, that is your phenolic glycolipid antigen of of M. lepra bacillus, and it is found in 95% of patients with untreated lepromyelitis with effective therapy. So we can detect the antibodies, and we can detect the antibodies, IgM antibodies to your antigen. This glycolipid antigen against antibody detect कर सकते हैं. Then we can go for lepromin test. We can do this. We can take this CMI, which is delayed hypersensitivity response to the lepra antigen, and it also indicates our intact host CMI. So we inject this antigen, lepra antigen, intradermally to fora, and then after 48 hours, if the duration greater than 10, that means they correspond to the response of late type hypersensitive reaction to the lepra bacilli. Delayed type है 48 hours बाद देखते हैं, ठीक है. So in the case the post exposure to lepra bacilli, and at 21 days, when the nodule is greater than 5 mm, if subsequently this ulcerate. So if this is positive, that is the patient CMI is intact, and if it is negative, that it shows that the CMI is absent. So we can go for the lepromin test. Then treatment recommended drug therapies, dapsone and fampicillin and clofazimine. The alternate drugs are ethanamide, quinolones, minocycline, and clarithromycin. So WHO, there's a WHO regime. For this, the 3-drug regime, that is WHO recommended 3-drug regime so that to minimize the drug resistance. So they give dapsone, which is administered daily, rifampicin once a month under supervision, clofazimine once a month under supervision, and 50 milligram daily or self-administered. Duration is prolonged. 6 months is duration is required for possibacillary. Possi है bacilli कम है तो उसका duration थोड़ा कम है. Then multibacillary 12-month treatment is required. Follow up annually for 2 years. Follow-up is required for possibacillary leprosy and 5 years for your multibacillary leprosy. Now coming to the prevention, to find the active case, that we have the program for it. So we need to find the active cases, and subsequently treatment is given. Then the BCG, they have not effective vaccine. we don't have any effective vaccine available for leprosy. Trials, are being conducted on BCG vaccine, um, alone or in combination with killed lepra bacilli. Then we have this MIT vaccine, which is still leprosy vaccine, was developed in 2018 using the Mycobacterium indicus freni, and trials are being conducted on this. Uh, 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 Dr. Garima, are you here? Dr. Garima, please unmute yourself.
Yeah, I'm here.
Yeah, yeah. Um, so students, we have a faculty from dermatology. She'll be taking 10 minutes upon the clinical aspect of case study. So over to you, Garima.
How do I share my slides? You have to stop your slide sharing.
And
Good afternoon, students. So we'll briefly discuss about the clinical features of leprosy. I hope I'm audible to everyone. Now, what are the cardinal signs of leprosy? Who is defined as a case of leprosy, and what are the cardinal signs of leprosy? So a case of leprosy is one who has one of the three cardinal signs, that is hypopigmented or erythematous skin lesion with definite loss or impairment of sensations. Secondly, involvement of peripheral nerves as demonstrated by definite thickening with sensory impairment and or motor weakness, and slit skin smear positive for acid fast bacilli. A case of leprosy is one who has any of those and has not completed the full course of leprosy. That is, it is 6 months for paucibacillary and 12 months for multibacillary. Now, coming on to brief clinical features. First is indeterminate leprosy. This is the earliest and transitory phase where you do not see a very clearly well defined patch. There may be one or two vague hypopigmented macule, but the sensory impairment is definite. This is the most common type of leprosy seen in children. Okay. It can progress to other forms of leprosy if it is remained untreated, and sometimes it can spontaneously regress also. It is bacteriologically negative. The second is tuberculoid leprosy. Herein, the number of lesions is very less, usually 1 to 3 lesions. They are distributed asymmetrically and are sharply defined, dry, flat, usually erythematous, can be hypopigmented with definite loss of sensation, that is anesthetic, loss of hair, hairless, and anhydrotic, that is no sweating. There may be one or two nerve enlarged near the skin lesion, that is nerve to the patch is enlarged, and lepromin test is strongly positive. Slit skin smear is usually negative. This is the classical presentation of tuberculoid leprosy, wherein you can see a very well defined patch. Now, coming on to borderline tuberculoid, here 4 or more lesions are there. They're usually ill-defined, and some may have satellite-like extensions or pseudopodia-like growth. They're usually hypoaesthetic. Lepromin test is weakly positive, and slit skin smear may or may not be positive. The nerves are also asymmetrically enlarged. Now, as you can see in this diagram, in some areas it is well defined, in some areas it is merging into the surroundings. There is a satellite lesion and some pseudopodia like outgrowth is also happening. Now coming on to borderline leprosy, herein varying shapes and sizes with punched out center is seen, that is classical Swiss cheese appearance with an ill-defined sloping outer margin. These tend to be asymmetrical. The loss of sensations may or may not be there. Nerves are also asymmetrically enlarged. Lepromin test is usually negative. As you can see in this lesion in the arm, herein, the center is clearly well defined. The outer borders can be merging with the surrounding tissue. Now, borderline lepromatous leprosy is usually numerically symmetrically distributed lesions. They can be multiple, hypopigmented, or irregularly shaped maculopapular infiltrating papules, plaques, and nodules with smooth surface and ill-defined borders. It can have inverted saucer-shaped appearance. The nerves may be symmetrically or asymmetrically enlarged, and there may or may not be any sensory loss. Lepromin test is usually negative. As you can see here, there are multiple hypopigmented, shiny skin lesions present on the trunk. In the second photograph, there are multiple erythematous shiny lesions here. So you can see two manifestations. One is slightly hypopigmented, but both of them are shiny. This shininess is an indication of infiltrative appearance of the lesions. Now coming on to lepromatous leprosy. Lepromatous leprosy is usually symmetrical. There is symmetrical nerve enlargement. There is symmetrical distribution of infiltrated lesions on trunk, face, extremities. They can be slightly hypopigmented or erythematous. Lepromin test here is usually negative, and in slit skin smear, multiple AFB are seen. Herein, you can see there is diffuse involvement of the entire trunk in the second photograph. And the first photograph, you can see multiple skin lesions, which are erythematous and infiltrated. So this is classical of lepromatous leprosy. Here you can see infiltration of the ear nodules. There can be diffuse infiltration of the thickness with loss of eyebrows, eyelashes, madarosis, and saddle nose deformity, that is leonine facies. This has already been explained to the students, wherein there can be tuberculoid difference between tuberculoid, that is TT, BT, borderline, and lepromatous. There can be multiple skin lesions, and as you can see, the bacteriological index is gradually increasing. The macrophages are usually epithelioid towards the tuberculoid pole, and foamy macrophages in the lepromatous pole. The Langerhans giant cells are mostly seen in the tuberculoid pole, and lepromin test is also positive in the tuberculoid pole. Now, lepromatous patient can have multiple skin lesions as well as involvement of other organs. The involvement of respiratory system, that is larynx, pharynx, involvement of bone, which can lead to osteoporosis, osteolytic lesions in the bone, kidneys, lymph nodes enlargement. There can be hepatosplenomegaly. There can be hypogonadism due to involvement of testis in the eyes. There can be iridocyclitis, iritis, iris pearls, nasal stuffiness, epistaxis in the nose. Multiple nerves can also be enlarged. As you can see here, there is enlargement of great auricular nerve. Other nerves can also be enlarged, such as ulnar nerve, lateral popliteal nerve, posterior tibial nerve. These are the most commonly involved nerves. This nerve enlargement can lead to muscle weakness, muscle atrophy, contractures of hands and feet. Ulnar nerve is the most commonly involved nerve, followed by lateral popliteal nerve. Least commonly involved is radial nerve. Okay, the most common cranial nerve involved is trigeminal nerve. At least 30% loss of sensations is required. 30% loss of nerves is required to demonstrate loss of sensations. The first sensation to go is usually cold, temperature, followed by fine touch, then crude touch, then pain, and pressure is usually the last to go. Proprioception is usually preserved. Now, if the ulnar nerve is damaged, that can lead to clawing of the hand, as seen in this photograph. If radial nerve is damaged, it can lead to wrist drop, as seen in this picture. And there can be foot drop if lateral popliteal nerve is damaged. If posterior tibial nerve is damaged, it can lead to clawing of toes. Now we'll see one patient. This is the case definition. This has already been explained. Now, if a patient comes to you, you take a history, do the clinical examination, then perform a slit skin smear. Rest 3, you have already learned the microbiology lecture. Okay, regarding the history, you should take into account what is the name of the patient, what is the age, which gender does he belong to, where is he staying, is any other person in the family also affected from similar illness, what are his complaints, has he had a contact with a leprosy case in the past, and what is the treatment history for leprosy, has he taken any treatment or left treatment in between. Now, coming on to physical examination, firstly, you do a thorough examination of the entire skin, how many patches are there, what is the surface of the patches, is there any nerve to patch, is there any anhydrosis, is there any loss of sensation, and then you, after checking all these details, then you do a palpation of the superficial nerves. Ulnar nerve is usually checked near the medial epicondyle. Great auricular nerve, when you turn a patient's head towards the side, you can see it over the sternocleidomastoid muscle. Lateral popliteal nerve is behind the head of the fibula and the dorsal branch of the radial nerve in the radial groove. Then you test for the sensations too, usually cold, heat, touch, pain. And then you check for any paralysis of muscles in the hands or feet. Herein we have shown how to check for each nerve. In the first photograph, you can see the doctor is checking for the radial nerve in the radial groove. In the second, he is checking for the ulnar nerve. And in the third bottom image, he is checking for the median nerve. Herein, he is checking for the posterior tibial nerve. And in the second image, for lateral popliteal nerve. Now, this 40-year-old married female resident of Delhi, the housewife, presents with chief complaints of multiple hypopigmented lesions on the face and arms with decreased sensation for the past 2 years. So there are multiple lesions, firstly. So, and they are hypopigmented face, arms, and decreased sensation. There is redness, swelling, and pain over the existing lesion since past few months. And there is history of intake of drugs, details of which are not available. So what do you think this patient has? This is the clinical photograph. What do you, does anybody have any idea which spectrum could it belong to? Does it belong to the tuberculoid pole or borderline or lepromatous pole? And while there is sudden increase in the swelling, pain, and redness over pre-existing lesions. As you can see here, there are multiple lesions: 1, 2, 3, 4, 5, 6, 7, 8. 8 lesions on the face itself. So it's most likely to be a borderline lepromatous leprosy. And there is a type 1 reaction which has led to the increase in erythema and swelling of the lesions. Now you can do a further demonstration of which all nerves are involved, what other body parts are involved, then we can come to a conclusion regarding the diagnosis of this patient. Further, it is required that you do a slit skin smear in this patient so that you can assess what bacteriological spectrum this patient belongs to. Okay, thank you, everyone. If anybody has any doubts or questions, please ask.
Any questions, students? You can ask her. So, Dr. Garima, there's one question for you.
Yes, ma'am.
Yeah, there's one question. I'll read it out. Why this case can't be of tuberculoid leprosy?
See, tuberculoid leprosy, the number of lesions in classical tuberculoid leprosy, there are 1 to 3 lesions. In borderline tuberculoid leprosy, there are 3 to 10 lesions. And these, the patient already has 8 lesions on the face. They might be having more lesions on the body also, as it is shown in the history. There are multiple lesions on the face and arms. So the number of lesions is definitely large.
So, okay, thank you, Dr. Garima, for explaining the clinical features in detail. Any more questions? So there's one more question, Dr. Garima, for you.
Yes,
Somebody is
ma'am.
asking that there is a superimposed type 1 reaction along with a borderline leprobatic leprosy.
Yes, the
Probably this is
superimposed type. Usually, type 1 reaction occurs in the tuberculoid pole, but it can occur on the lepromatous pole also. And you can see some of the lesions, they are merging onto the surrounding skin. That is also indicative of borderline lepromatous leprosy.
so. Yeah, that's all. Thank you, Dr. Garima.
Thank you. Thank you, students.
Yeah. Am I audible? Can you see the screen? Am I audible? Okay. So another important topic is non-tuberculous mycobacteria infections. And you can also get question in this NTM, also known as NTM. These are atypical bacteria. And these are diverse group of mycobacteria which are split from birds, animals, and environmental sources. And they are mostly they are opportunistic pathogens. And they which are associated with human infections. So they most commonly cause infection in immunocompromised individuals. These are opportunistic pathogens, and in this, the man-to-man transmission is not known. Unlike your tuberculosis, Mycobacterium tuberculosis, in NTM, the man-to-man transmission is not known. And you have the saprophytic mycobacteria. These are the ones which are associated from soil, water, and other environmental sources. These per se they don't cause any disease in humans. So we have this NTM, we have this saprophytic mycobacteria, which does not cause any disease. So these NTM, they are classified into 4 types, groups by Elimination classification. There's the photochromogens, non-photochromogens, and rapid growers. The photochromogens, photochromogens is pigment. Photo is light. So these produce pigment only in light. Okay. So this includes species like Mycobacterium marinum, Asiaticum, Simiae, Kansasi. Then photochromogen, they produce pigment both in dark and light. It includes Mycobacterium, Strophylaceum, Schulgai, Gordoni. Then non-photochromogens, they do not produce any non-photochromogens. As the name suggests, do not produce any pigment. It includes MAC, that is your Mycobacterium avium intracellular complex, which causes pulmonary diseases, then Zenopi, ulcerans, paratuberculosis. Then these are the rapid growers. These grow within 1 week, which includes Mycobacterium chiloni, Fortitium, Spigmatis, abscessus. So this is a group of these are the groups of NTM, and you need to remember this because you may get a question on NTM. So yaad karna is very easy. As the name suggests, photochromogens, pigment is produced in light, photo is dark, both in light and dark. Then non-photochromogens, the pigment produced hoega hi nahi, and rapid growth, the name suggests, they grow rapidly within a week. We all know that mycobacterium takes long time to grow, 4 to 8 weeks, 4 to 6 weeks, but these they grow within 1 week. And please remember 1 or 2 examples. So these photochromogens, like which includes Mycobacterium marinum. These are acquired from water sources, and so they enter through the mineral trauma. These leads to formation of swimming pool granuloma. They form papules and ulcers as they're in the water. So one can get infection while swimming, or also known as fish tank granuloma. Then Mycobacterium asiaticum. They are rarely associated with pulmonary disease. Then we have M. simiae. They are isolated from pulmonary disease, pulmonary lesions. Then M. kansasi, they are responsible for chronic pulmonary disease, which resembles tuberculosis. So M. kansasi, it resembles your tuberculosis. Then photochromogens में Mycobacterium strophylaceum, it causes profula in children. Then Gordoni. These are commensal in tap water, so these are common contaminant in skin in your clinical specimen. So these are the various examples: photochromogens, the non-photochromogens, that is MAC and avium, intracellular complex. They are commonly seen in HIV individuals where the CD4 count is less than 50 per microliter. And then xenophi causes lymphadenitis, disseminated disease, commonly seen in hospital water supplies, and also responsible for nosocomial outbreaks. These rarely infect the HIV individuals. Then N. ulcerans, they causes Buruli ulcers, which are painless ulcers and nodules, which later become necrotic. And this may also lead to osteomyelitis and limb deformities. Then these rapid growers, M. fortitium and M. chiloni, they causes post-trauma infection, injection abscess, and the catheter-related infections. Then M. abscessus, they causes pulmonary infections. So we can classify them according to the clinical manifestation. Pulmonary infection, MAC is most common. Then lymph node may also include MAC. This is how you can remember them. The cutaneous manifestations are caused by M. marinum, M. ulcerans, which causes Buruli ulcers. M. marinum causes swimming pool lesions. Then your disseminated infections are caused by MAC and Kansasi. So how you will diagnose the disease? According to the symptoms, you will take the sample. If it's called pulmonary infection, you take the sputum. If infecting your, skin, you'll take skin biopsies, abscess banarapa. So accordingly, you will take the sample. And again, similarly with what you do for mycobacterium tuberculosis, because we do seal staining, with see the acid fast bacillus. Similarly, we will do here ZN staining, and they will show these red fast bacilli. We can culture them on LG medium. Several species of NTM, they grow well on the LG medium. You can culture them on the LG medium, the media. Then they produce pigment. So when we culture any sample, when we look for any mycobacterium species, that is a tuberculosis or NTM, we uh, uh, we culture them, we incubate it, and we incubate it both in dark and light separately, so that we can distinguish them whether it is photochromogens or photochromogens. So according to the pigment production, whether it is occurring in light or if it's occurring both in light and dark, we can categorize them. Then the other methods of identification, we have this NPT64 antigen, which we can detect by immunochromatography test, which is positive in case of M tuberculosis. So in NTM, this will be like कोई भी bacteria, mycobacterium sample आता है, so it can have a pulmonary, if there's sputum sample. So if patient may be having tuberculosis, it may have NTM also, because as I told you, there are NTM also, there are mycobacterium, other species, NTM species, which can cause pulmonary infection as well. So how do you can't be by sometimes the clinical symptoms are overlapping, the pulmonary symptoms and X-rays and also. उसके लिए हम क्या करेंगे, हम कल्चर करेंगे. So we will look for the NTM as well, whether the any producing any pigment or not. And if it is not producing, because there are some which don't produce pigment, so how you will distinguish it from tuberculosis? Tuberculosis, we have varieties of tests available. You all must be knowing by now. So we'll do those. If those are negative, then we can we identify it whether they are biochemical available as well, or we can go for some other modified, other molecular tests like PCR or multitox. So what is the treatment? M-avium, intracellular complex, the M. kansasi, M. marinum, they require multi-drug therapy with macrolide, ethambutol, and rifampicin. And these NTM, they are mostly resistant to first and second line tuberculosis drugs. So drug treatment is different from that of your tuberculosis. Mycobacterium tuberculosis. So that is why the identification of NTM is also important as well. So that is all. Uh, I end my lecture here. You need to know it's important topic. NTM is important topic as well. You do get a question on NTM in leprosy also. You may get a question in difference between the lepromatous leprosy and tuberculoid leprosy. What are the types of clinical manifestation which can be seen in case of leprosy? Then difference between the lepra 1 and lepra 2 reaction. These are the common